on the agenda is the GME. I'll open up for discussion regarding as a potential BDR. What are the thoughts of all the commissioners?
Yes, Chairman Khan, Wendy Simmons for the record.
Uh-huh.
Based on the wonderful information that we received and knowing that basically Medicaid is asking for the potential to have flexibility, on the utilization of accessing federal funds, I would like to suggest that that we consider as one of the BDRs, moving the GME to Medicaid's budget. And I do know that that's going to take a bill.
Okay, how about other commissioners' thoughts on this?
I would second that motion.
Okay, we have a motion on the floor, seconded. Any further discussion on this motion?
I think the ask was that Medicaid funding could be used and the authority be given to Medicaid to be able to use Medicaid funding. And so I just want to be clear on that there may be other programs throughout the state related to GME and IME and other things, but that Medicaid could be a source of funding.
Authorization for budget authority, I believe, is exactly what was used.
Yeah, thank you.
Is that correct, Director Whitley?
Yes, and I actually like.
All right, so we have a motion. We have the language proposed. Again,
is that okay, Director Whitley? I think he was finished. Yeah, I think he was.
I did like the addition that that Bethany indicated of and other funding sources being included, but it really is the mechanism of being in Medicaid's budget that allows us to leverage it with federal funds that Wendy made. So yes.
Okay, any other comments on this before we just take a vote?
So can we restate what the motion is? I want to say that it's to provide Medicaid with authorization for budget authority to leverage federal dollars to grow GME in the state. Does that sound about accurate?
I think it needs to be dollars, not federal, because we want to allow funds to come in.
Thank you.
A variety of funding sources or something like that. Mm-hmm.
Yeah.
All right. Did the DAG get it?
I apologize. I have to jump
Are
off.
you all moving for that BDR topic for consideration? Is that the motion? Okay, thank you.
Yeah. Okay. So any opposed to this motion as a second BDR topic? If none, then this motion carries. So now it brings us, we are allowed up to 3 BDRs. So we have approved for further discussion 2 BDRs for consideration. We have an opportunity for a third one. On the nursing thing, do we want to keep that on a potential BDR based on different language or information that will come through and discuss at the next meeting?
Dr. Klein, this is Marilyn. So I personally don't want to waste a BDR on that. I'm willing to work offline with whoever wants to try and do some other stuff, but I personally would rather see a BDR that is general on reducing barriers to workforce, because that's really what the Patient Protection Board was set up for in the beginning. And it wasn't set up for one or the other. And I think that you could put a bunch of things in a bill, but I would work with others on, maybe there's some pieces. I need to understand why folks want a nursing compact. So I'm worried about the bench. I'm worried about the kids today. I'm worried about if we don't create a bench, we're going to be in the same boat 10 years from now. So I would just like something broader. I'm not willing to waste my vote on a BDR that I know what happens to it. It puts kids in somebody's drawer.
So I'm personally with you also on that. So let's talk about it. If this is not with the other commissioners here, if this is not a BDR, we have also proposed earlier, it can come as a potential recommendation from the commission towards the end. And that also carries a lot of weight because it becomes official record as a consideration, as a recommendation, if we all vote for that aspect. If that is the case and the commissioners are on board, then we have to select a third topic so that we can narrow it down so we focus on specifics at the next meeting. So we have an option of a third BDR. So any thoughts from commissioners on their priorities on the third BDR?
This is Bethany, for the record. I would maybe suggest to Marilyn your point, and actually the thought about building the bench. Is there something around some of the funding that I think Joseph mentioned for apprenticeship programs, and trying to think about how we make that more permanent and sustainable over time? So would love to maybe open that up as a thought, as a backup to the nursing compact idea. Because I think nursing is an area of core need within the state. And so, would love to try to see how we put something in that space related to nursing specifically.
So any other comments on that thought? Marilyn,
Well,
do you have any thoughts?
Or Flo, Connie, you have your hand raised. Go right
I
ahead.
do, not on that particular thing. I just want to follow along on, I think what I can't say, but what Wendy said and what Marilyn has said and others about just the administrative burdens. I think there's a lot of things, whether it's in credentialing or it's with the providers on prior auth, or some of the administrative burdens that I think are fairly, I don't want to say simple to do, but I think from a BDR perspective, it could be fairly easy to like craft and identify some of those hurdles that we could address. Like I said, quickly. I hate to say quickly because nothing is quick or easy, but just some of the low hanging fruit that we could do, and those would really impact providers and the provider short, easing some of the burdens on our providers. It could also be on the licensing and credentialing side, where we could speed up some of the processes, eliminate some of the duplication that's occurring, that is hindering our ability to either attract or retain these healthcare workers. And I think that goes to our objective, which is really to increase the availability of these different providers. And so I think that kind of falls nicely. There's a lot of different ways. So it could be more general and broad-based in providing authority to eliminate within these agencies, to eliminate some of those redundancies or whatnot at their discretion. It could be for the prior auth, understand, what do we need to do there for the providers to relax with identifying certain procedures or treatment options or whatever that we know are going to be approved. So let's make it happen. That's just kind of where my thought is in terms of where a BDR should go.
So on the authorizations denial, I think as you heard earlier, a lot of that comes under the insurance commissioner. A lot of the stuff comes under the commissioner's domain. So I think my view is that we can discuss with the insurance commissioner what can they handle at that, and for all these obstacles and delays in prior authorizations of services, and more importantly, denial of services that are legitimately needed for that patient. It's very painful for a patient to have the perception that they have insurance only to find out it's denied. In my opinion, not necessarily for a good medical reason, because I see this every day. It's not necessarily a good medical reason. It's just that it's denied.
So Flo, can I offer this though? So some of the things that you talk about, absolutely right. And that kind of was my point with modernizing our system. And I think some of that can fall under the Medicaid reimbursement bill, depending on how you write it, because you'd want to tie it to something, because we want to make sure that they're seeing our poorest of the poor as well as the others. So I think that what you're talking about is not lost, and maybe it's how you write that Medicaid reimbursement stuff.
I think that sounds very good to me, Marilyn. Obviously, your expertise.
My gosh, I feel like I'm in the legislature. I'm not trying to.
Yeah, that's very helpful. And I think you make a very good point. If we can, perhaps, in my opinion, somehow incorporate in the Medicaid bill, or BDR rather, uh, perhaps it'll cover that aspects of the subjects we are discussing. Does that make sense to you, Marilyn?
Yeah, that's fine. I just think that the last BDR topic should be breaking down barriers to workforce. I mean, that broad, and then we can work in our little groups. In the next topic, we could spend a bulk of our time just talking about that.
Any other comments on that?
It had felt to me like when we heard from Stacey Weeks that a lot of that administrative burden, at least on the Medicaid side, was sort of already being addressed through some of the administrative work that I think she was doing. And so I'm just wondering, agree, could be pulled into the Medicaid funding bill or BDR, and or could we also have it as a recommendation for, you know, not only Medicaid, but potentially the Department of Insurance or other things. So
What are the commissioners thinking? As a
I don't
recommendation or
think so.
otherwise?
Yeah, I think it's fine. I think it's just what's going to need legislative change versus administrative change. And if it's a legislative change to give them the authority to do that, then we may need to do that. So however, wherever it fits in, I just don't want us to run up, and this is where our attorney on record can help us direct, but making sure we're not going through over like a single source or a single bill topic, you know, issue, and that we're trying to do too much in one proposal that kind of crosses over the line. So we just need to make sure that we're following along and following our, you know, legal standards in terms of what we're putting into a particular BDR, but agree, however that could work.
Okay, so DAG will look into it.
I guess we would just need to, and we can even discuss this between now and the next meeting, just getting some specific feedback from you all on what specific administrative burdens we're wanting to address. I know we've mentioned prior authorizations and the central credentialing. I know that Medicaid is currently working on establishing that already, so not sure if that would take legislation. So maybe if you all sent me your recommendations on that specifically, on what administrative procedures you'd like to have Medicaid address, and then we can identify if that's already occurring or if that can occur through regulation versus legislation.
Does that make sense to everybody?
I agree with that. I think honestly, we're gonna have to do that on all three topics, right?
Yeah, that's true. So any other thoughts for a potential third BDR? There's an item that was suggested on unfunded mandates. Richard Whitley is online. How big of a problem is this of unfunded mandates by Medicaid? I know there is always talk about the unfunded mandates for the insurers.
And Richard, let me give you a little background on that. So we had Joseph Filippi for the record. So we had a recommendation. Sorry, I'm trying to find it. Okay. Recommendation to ensure any state mandated medical benefits be included in any state controlled insurance product, such as Medicaid, managed care, or PEB. So that wasn't identified as a top area. So, but I did do a little bit of research. I reached out to Medicaid and also PEB, and we had some information on that. So basically, what I was told is that, you know, if a state was to mandate to cover a specific medical benefit, that doesn't necessarily mean that CMS would approve that or fund that. And so if it wasn't approved at a federal level to fund, then the state would have to fund that through general fund. And we've talked about the limitations in that. And so that's just one consideration there. And I'm sure Administrator Weeks potentially could speak to it more detail. But then, and we have a representative, Director Glover from PEB as well. But I don't know, Celestine, if you want to go ahead and say that from PEB's perspective. But basically, if there was something in this regard, it could also end up increasing premiums for consumers and whatnot. So there is some more that we would have to look into on this topic, I think, and happy to share this feedback with you all. I hadn't done that quite yet, just because this wasn't identified as a top 3 priority yet, but questions.
Dr. Khan, it's Marilyn. So, but the third topic was the nursing compact, and I said I specifically can support the nursing compact, but we should have a workforce bill. So, are you scrapping that, or only because that was one of our charges was to have some type of workforce component to what we were submitting forward. So I'm just.
I think we don't have that spelled out, do we, Joseph, on this workforce language? Or Marilyn, you're suggesting some language for that?
I think we're just trying to see how that ties to workforce. And, you know, as the governor has, you know, brought you all together this year to look at healthcare workforce, ideally any BDRs that come out of this commission would be addressing that specifically. And so the Nurse Licensure Compact, even though, you know, there is hesitation regarding that, it does address workforce. And so that's why it was identified, I think, as one of the top topics for discussion today. Doesn't mean that we can't pursue or look at other areas for potential BDRs, but just wanting to, I guess, question that specific topic.
Marilyn,
I hate to interrupt.
Go ahead.
I hate to interrupt, but I have to jump off. And so I just wanted to let the commissioners know that I have to leave. So
thank you very much. Appreciate your time.
Yes, thank you.
Maybe Dr. Condon, the issue is the issue, and I'm sorry, Bethany, I know you want to speak. You have to just speak out, I think. But maybe then we just do the third topic next time, because we've all been through this, but I don't want to lose sight of, you know, what people were saying nursing is important to them and they want to move forward. And I feel like we got to have a workforce bill. I don't know that it's specific to one compact or another, but I just feel like we got to have a workforce bill, and maybe we just take it up next time because it is getting late for people.
Yeah, which makes sense to me. So come up with your thoughts and please share it with Joseph on this workforce potential BDR. Is everybody in agreement with that? If
Bethany, do you want to say anything, or?
I wanted to come back to the fourth item on the list, I think, just maybe for clarity of what the intent was there. So there are oftentimes through the legislative process that benefits or other mandates are made. And what ends up happening is that those mandates are not necessarily applied evenly across all insurance products, right? Because Medicaid will be exempted or PEB will be exempted or other things. And so then you have those hitting commercial insurance. And the idea is that if we had, and other states have this, regulatory requirements around mandates like that having to be applied across all benefit structures, all products, then you actually go through the due diligence of understanding what are the cost implications, what is the actuarial value to those sorts of scenarios. And I think it puts in place more rigor around actually analyzing the impact of access to care, you know, the cost of care and all of those things, which we've heard throughout all the various presentations. We have discrepancies, right, where commercially insured folks get differential access because of the rates that are being paid and benefit structures and other things. And so the idea was if we can create a level playing field with a bit more thought put in at the front end, then we actually may true up some of that access to care. So just wanted to put that out there on line item 4.
So Bethany, I don't disagree with you, but maybe Mr. Kipper agreed to have an offline conversation. Maybe it's a BDR that he can do to look at it. So, I'm exhausted. Are we done, Dr. Klein?
Yeah, we are almost actually there. Our colleagues have thoughts. So let's hold that thought for our next meeting that we just talked about also. Basically, I think that brings us to the end of our thing, except the next one is any public comments registered, Joseph?
Thanks, Dr. Khan. Joseph Filippi for the record. So once again, this is the second opportunity for public comment. If you're joining by Teams today, please raise your hand through your computer, or you can press *5 if joining by phone to raise your hand as well. It looks like we have a request from David Carlson. Please go ahead. You have 3 minutes.
This is David Carlson. I think you can spell Carlson, perhaps. I am the Associate Dean for Graduate Medical Education in Northern Nevada with the University of Nevada, Reno. And I want to thank everyone on the committee and all the presenters for the advocacy of getting GME somehow perhaps into the Medicaid budget. Based on what I heard today, I just wanted to make a few comments. Without GME, we don't keep as many of our graduating medical students in the state. We graduate now about 314 students across our various medical schools. And actually, in terms of how many stay in the state, Nevada ranks 21st in terms of those who have graduated from one of our medical schools and are now practicing actively in the state at about 39.8%. If you've gone to graduate medical education program, but perhaps not gone to one of our medical schools, Nevada ranks 6th in keeping those people in the state at 55.2%. And if you've done both, Nevada ranks 8th amongst all states in keeping 76.9%. So it's very important that we can finance GME. The operating costs are very important. Startup costs for new programs are anywhere from $2 to $3 million. Operating costs are approximately $150,000 per resident per program. And case in point was the ELCO issue. It was more the operating costs that caused that program to stop. Northeastern Hospital decided not to continue to pay for that, and that was a business decision of theirs. And so that was really an ongoing operating cost that caused that program to close. We are currently expanding our own GME footprint from the University of Nevada, Reno. We just started a new pediatric program, which has finished its first year, but it needs more operating costs to continue. I'm about ready to submit probably this afternoon or maybe later this week a application to the ACGME for an OBGYN residency program, probably start in July of 26. Again, we need operating costs for that. We are looking at an addiction medicine fellowship that we might be submitting soon. The family medicine rural residency track issue, we are in conversation with a couple of communities about the possibilities there. Again, operating costs are going to be necessary. And we're right now looking at 4 other programs that we hope will keep internal medicine residents who might be here to stay here for their particular fellowships, and actually also a general surgery program.
Sorry to interrupt you, Dean, but the interest of time, we have already narrowed down as one potential BDR for GME. So we would appreciate if you could submit these details to Joseph, and he can circulate all this information to the commissioners, because we'll be discussing at greater length on this potential BDR topic at the next meeting.
Thank you very much.
Thank you very much for your time. Anybody else for public comment?
Chair Khan, I'm not seeing any other hands raised.
Okay, so I had asked for maximum by 12:30. So Marilyn, sorry about that, but thank you very much all for your time. I really appreciate it.
Yes, thank you. Hope you all have a good weekend.
Thank you.
Thank you.
Bethany, did you want to reach out? Oh, she hung up. Okay, never mind.